All right, good morning, everybody, or good afternoon. Um, it is now noon, so we'll get started. I believe some other folks may join in the next few minutes. My name is Lindsay Simpson. I'm the project coordinator at the Center for Evidence to Practice. We're at the LSU Sciences Center in New Orleans, and we are working with the Office of Behavioral Health to expand access to evidence-based practices for children and families receiving Medicaid services throughout the state. So thank you, everyone, for your interest in PCIT. I'm going to hand over the mic to Dr. Amy Herschell. She is a master trainer for PCIT, and she's based at the Early Childhood Innovation Center in Pennsylvania. She's done extensive research on implementation science for PCIT, and we're really excited to have her on board and supporting our work in Louisiana.
So thank you, Lindsay, and thank you everybody for taking the time out of your very busy days to learn a little bit about parent-child interaction therapy, or PCIT. What I had hoped to do was talk a little bit about our training team, give a little information about what PCIT is, talk a little bit about the style of training that we anticipate doing with this group, and then talking about very specifically about what participating in the initiative would mean. And I am a big fan of knowing details from the start of an initiative. So we'd like to provide you with as many details as possible so that before you think about submitting those applications, you have a real sense of what the year together would look like. And then I thought we'd talk a little bit about next steps. But before we get going, I wonder, it sounds like, Lindsay, you were going to do a poll to just get a sense of how many folks we have on the call, and also what their roles might be so that we can make this hour together hopefully as useful to you all as possible. So and I think also, Lindsay, you were going to mention something about the chats.
Right, so I will throw up the poll in just 1 second, and anytime throughout this conversation, if anybody has any questions, I know this will be a lot of information, but please just remain muted and type your question into the chat box. You should see it on the bottom right-hand corner. So at the end, Dr. Herschell will answer all the questions. We received a few through the survey link that we sent out when we announced the webinar, so we'll make sure to answer those as well. And anything that doesn't get answered today in this webinar will follow up over email. All right, so I will bring up the poll.
And I also wanted to mention, I wonder if some folks I see more people are joining as we're getting a little past an hour. I got a text from Sarah, one of our trainers, that she will be on as soon as she can. She was having a little bit of some technical difficulties, so I wonder if some other folks are as well. But I think you've mentioned some important points, Lindsay, which are, if you have any questions at all, we really do want to make sure that this hour is really as helpful to you as possible. So any questions at all, please send them in through that chat line. Also, I can see already that many people have their phones muted, and we appreciate that because it just cuts down on the background noise. Are you recording this as well, Lindsay?
Yes, this is being recorded.
So that will be important too. And Lindsay, I noticed you put up so people could just let us know what your primary role is within your organization. If you're a clinician, supervisor, or senior leader, that would be helpful. Senior leaders are usually folks who are administrators in your organization. Sometimes chief, they can go by lots of different names: director, executive director, CEO, CFO. So if you fall into any of those roles, if you could just click the senior leader, that would be helpful. right. Okay. I was trying to think, are there any other, the other detail I wanted to mention was, Lindsay, if at any time you have difficulty hearing me, can you just interrupt me and let me know?
Yes.
Okay, thank you. All right, then we'll just keep on keeping on, and hopefully a few more people will join us. And you'll let me know when you have the results of the poll, right?
Yes. So, Amy, it looks like, and I'm not sure if you're unable to see the poll results, but we have 50% of folks on the call are clinicians. We have about 25% who are supervisors, and 38%, 3 out of the 8 are senior leaders. Just to give everyone a little of an idea of who we have with us today.
That is very helpful, very, very helpful. And it's nice to see that we have a good mix of folks. So thank you very much. All right. Well, I have this quote up here, which hopefully many of you are on the webinar and can see. But for those of you who might be dialing in, I'll just read it for you, which is, the single most common factor for children who develop resiliency is at least one stable and committed relationship with a supportive parent, caregiver, or other adult. And so I really appreciate this quote, and I hope that it helps put in perspective what we're about to talk about, because that really is the goal behind PCIT, is that you help stabilize the caregiver and the parent-child relationship, because we all know that what's most important in a young child's life is to have a committed caregiver who is who has a nice style of providing positive attention as well as consistent, predictable limit setting. And so that's what we're going to talk about, and that's what PCIT is all about. So I thought I'd begin by just telling you a little bit about our training team. If you decide to participate in this initiative, you'll get to know us all very well. Here are our pictures. This is me, Amy. And I'll say, I know Lindsay did a nice job with her introduction. I'll just add that she is right. I'm a master trainer. Sorry for my distraction. Lindsay, Sarah is having a hard time getting on, so she emailed you about that. But so I am a master trainer certified by PCIT International. I've been doing PCIT for a long time, and I have done PCIT as a clinician, but also have supervised a lot of broad-scale implementation of PCIT. We have been trying to scale PCIT up across Pennsylvania for about 10 years, and I'll show you that in just a minute. I have the good fortune of working with these 3 who are depicted on the slide: Dr. Kristen Schaffner, Ashley Scudder, and Sarah Tabor-Thomas, who will also be trainers on this project. We have been doing this work together for a long time, and we really value team-based work, and bringing together the expertise of different folks. So each of our trainers have different expertise, which I think helps when we're doing large-scale projects like this one. So just as examples, Kristen is a school psychologist by training with expertise in implementing teacher-child interaction therapy, which is kind of a next step with PCIT. Ashley has lots of training and expertise in delivering PCIT in primary care settings, so integrating behavioral health with physical health. And Sarah has expertise in implementing PCIT with families who are referred from and involved with child welfare. So it's a nice complement when we think about how PCIT can be implemented with other populations and across child-serving systems. We also, with this project, are going to work to bring in some Louisiana-based clinicians who have already been implementing PCIT, because what we have learned is that it's so, so important to understand the local context and to have localized expertise, So we have a call coming up in a couple of weeks with a few people who've been implementing PCIT across Louisiana to hopefully involve them within our training team so that we can make sure that we're sensitive to the needs of your communities. I thought I would just mention, I think one of the reasons that we were chosen to be your PCIT trainers is because we do have experience with implementing PCIT pretty broadly. I thought I'd just give you a visual. This is Pennsylvania. I'm located in Allegheny County, which is where Pittsburgh is, on the far left where there are a lot of little dots, if you can see them. Each of these markers represents a PCIT program that we helped to develop. This was in 2011 when we had been implementing PCIT for about 5 years. We then got a grant from the National Institute of Mental Health to study and to implement PCIT more broadly. So this is what it looked like in 2017. Each marker indicates, red markers indicate agencies where we have PCIT clinicians, and blue agencies represent where we have clinicians and within agency trainers. Because our goal with this project, I think much like the goals of your center, were really to make sure that if there were a family across our state that wanted access to PCIT, that they would have access to it in their own community. And so we worked to scale it up so that we essentially developed a little over 130 programs across 130 agencies, 62 out of 67 counties, and trained over 300 clinicians. So I think that's why that's what we hope to be able to help with is certainly training, but also thinking through some of the things that will be important for your state as well. So thinking about scaling it up, having steering committees that help with the system level issues that happen when you're embedding evidence-based practices into a state, and thinking about how over time you might expand with PCIT to embed it in different service lines. Like for example, in Pennsylvania, we do an in-home version of PCIT because what we found was that the clinic-based was great and still is strong, but there were families who could only be reached by going to their homes, and so we developed a plan and an approach that's a modified version of PCIT where we take it on the road. And we also have worked to have an enhanced rate. So PCIT providers in Pennsylvania get paid more for providing PCIT as compared to traditional outpatient services. So we're hoping to help with the training, but also all of these other things, because ultimately those other pieces are what will help to be able to sustain PCIT and to support PCIT clinicians in your communities. So you already probably know about what PCIT is, but I thought I would give you an overview. So PCIT is an evidence-based treatment for young children aged 2.5 up to about 7 who are coming in with high-level disruptive and externalizing behavior problems. Those are the kids for whom PCIT was developed. It also has now been expanded to treat other populations and presenting concerns, but initially we like people to start with this population, and then once you know how PCIT will work and where you can expand it or extend it, then that's kind of a second step, because it's just helpful to have the foundational skills with the population with whom it was intended, and that's these young kids with behavior concerns. It is considered an evidence-based practice for this population, and there are dozens, not a couple, but dozens of treatment outcome studies showing its benefit. Many of you probably already know, but we do in PCIT work with the caregiver and the child. So this isn't a treatment where somebody comes in and drops their child off for the 50 minutes. Instead, it's very active, action-oriented, where the caregiver interacts with their child and gets feedback from the therapist using this coaching or with some technology, which I'll show you in just a few minutes. But an important point here is that when we say caregiver, I feel like parent-child interaction therapy with the parent in the lead is a little misleading because we really involve any caregiver. So birth, kin, foster, adoptive, grandparents, extended family. We believe the more the merrier. So we've even had, and not just one caregiver, if there are multiple caregivers involved with the child, we're happy to have those folks involved as well. So that sometimes means 2 caregivers if we're super lucky, but it can also mean a mom and a grandma, a mom and a Head Start teacher we once had. Any combination of caregivers, we're happy to include them because the ultimate goal is to get everybody on the same parenting page. So you may know, PCIT has 2 phases. The first phase is child-directed interaction therapy, or child-directed interaction, CDI, or some people call it relationship enhancement because it's all about promoting a warm, nurturing relationship between the child and the caregiver. And many times in this phase, we'll see that behaviors really start to come down, and sometimes caregivers are happy enough with the treatment at that point that they're ready to be done. We almost always encourage them to stay for the second part of the program, which is PDI, which is focused on consistent limit setting and child behavior management. So the intention behind having these 2 phases in PCIT is that we're trying to help caregivers to the optimal parenting strategy, which is one that balances warmth and nurturing with consistent limit setting. And so accordingly, the first phase focuses on nurturing, relationship enhancement, and the second part focuses on behavior management and consistent, predictable limit setting. And so here you see the goals of the treatment. It really is that through this, PCIT is very much a relationship-based therapeutic approach. And what we're doing through that caregiver child-parent relationship is all the things that you would hope are happening. You're building up this and promoting this warmth between the caregiver and the child. At the same time, the child is learning all kinds of wonderful things from the parent. They're learning how to have a good relationship with an adult, how to be respectful of an adult, how to share, how to take turns, how to use nice language, how to use an indoor voice. All of those pro-social behaviors we see increase, and just what then naturally happens is that we see a decrease in some challenging behaviors. The idea with PCIT is that we want to create enduring change for both the caregiver and child. The intention is we catch these children really young, and then we help get them on a healthier developmental trajectory so that as they go on, they have these great skills in place where when they go out in the world and interact with other people, that they get a much warmer reception and reaction from people because of their good behavior and ability to engage in a healthy relationship. So PCIT is most appropriate, like we mentioned, for those young children who are showing some disruptive behavior. So things like verbal or physical aggression, downright defiance, non-compliance, temper tantrums, running away from their parent, getting in trouble at daycare and at school, arguing, fighting with others. Maybe some of these kids might sound familiar to y'all. They're the kids that we love. We love to see them in PCIT because we know that we can make a very big difference with them. PCIT is also appropriate for parents who use harsh or overly punitive parenting styles. It is one of the few approaches that's considered an evidence-based practice for families who are referred from child welfare and involved with child welfare. is particularly helpful for families who've had high-level family conflict and child physical abuse. And also it's appropriate for parents who could benefit from an enhanced relationship or behavior management skills. Because we actually have some parents who come and say they would just like to improve their parenting approach. And PCIT is a great fit for those families too. I'm going to pause. Do we have any questions, Lindsay, that might be appropriate in these sections? Or does anybody have any questions at this point?
So I haven't any questions yet that pertain to this part of the presentation, but we do encourage everyone to put your questions in the chat box, and Dr. Herschell can take them as they come up.
Okay, then I'll keep going. Some of the things that you might think, well, oh, this doesn't sound very different from what we already do. And I bet that's the case. Though I bet PCIT structure might be a little bit different. So these are the things that make PCIT unique. So the parent and the child are seen together in treatment. There are only a couple of sessions throughout the whole treatment process where you would only see the caregiver. And those are what we call teach sessions. So we mentioned how the approach is divided into two phases, child-directed interaction and parent-directed interaction. Each of those phases start with the therapist meeting only with the caregiver to go over the skill sets. But then after that, every session will involve the therapist coaching the parent in the skills that they've reviewed during that one teach session. So parents and children are together. It's very action-oriented. Parents are not given general information. It's very specific, and then they're coached in those specific skills. I bet you can already hear it, but PCIT is theoretically grounded, and it's focused. A lot of care has been taken to incorporate developmental psychology principles and concepts within PCIT. It is focused on interaction patterns. We are changing behavior through the way that caregivers and children interact with each other. So instead of having sticker charts for specific behaviors or things like that, we're going to change behavior through the interaction pattern. Like we've talked about, very active skill training. It's performance-based. So throughout treatment, it's not a model where it's a specific number of sessions. I can give you a range of sessions, but how quickly a family progresses through PCIT is based on mastery of skills. So there's not a specific time limit. Instead, it's based on how parents learn the skills and how they apply them with their child. And if both if the parent's skills are improving, the child's behavior is coming down, decreasing. And if everybody feels comfortable is how you progress through treatment. Like I mentioned, it's empirically supported, and we'll talk about that in a minute, and it is assessment driven. So data is collected at each session, parent report of child behavior, and then therapist observation of parent skill, and that's what drives each session as well as progression through the treatment. So this is just an example of how some PCIT rooms are set up. You can see here that we have a caregiver and a child. They're at an adult-sized table with adult-sized chairs. The caregiver has you can't see it very well in the picture, but she has a bug in the ear device, which then is, it's essentially like a hearing device where there would be a therapist, like if you look in the mirror, this is a one-way mirror. On the other side of this mirror would be the therapist. So parent and child are in the room together. Therapist is in an observation room. And the therapist has a microphone that then only the parent can hear the therapist through that bug in the ear device. And what happens is during a PCIT session, essentially they go pretty similarly in that you have, the therapist has a brief time where they check in with the parent, they see how the week has gone, what the parent would like to focus on for the week. Then the parent and child are in the therapy room together. The therapist exits, goes into the observation room, and then the therapist will observe the parent and child interacting for about 5 minutes. And then after that, the therapist coaches that parent in interacting with the child. And what happens then is that it really gives the therapist a unique vantage point. So they can help the caregiver to apply what we think of as, there are some things that I think therapists naturally are skillful at that are really tough for parents to implement with their children. And so we take really complicated topics and boil them down into building blocks and then coach the parent in those building blocks. And so instead of, for example, there are certain developmental norms or developmental milestones that are tough when you read them on a page to understand what that means, because parents are usually concerned about wanting to make sure that their child is on track. Well, even with the coaching, we certainly coach PCIT skills, but you can also coach things like developmental, how to help with developmental milestones, how to notice when children are hitting those developmental milestones or when they're engaging in developmentally appropriate play. You can coach the parents in helping them to regulate their own emotions. There's all kinds of things that can come through that coaching in the bug in the ear device. So it really is a critical element of the treatment. Another thing that I like to mention early on is that this approach does include, in the second part of the program, we do a timeout. And if children won't stay on the time, many of the kids who come in to PCIT are ones who have had difficulty accepting limits and consequences, including timeout. And so we often have to help teach children to sit on a timeout chair. And so we do that through a pretty sophisticated timeout procedure, which involves a timeout chair and then in some cases a timeout space. But when I say timeout room or timeout space, I feel like that can be pretty scary and bring up a lot of concerns for people. So I thought I would show you, this is an example here of one of the timeout spaces in a local clinic here. So if children can't sit on the chair, then they might have to go to this timeout space. 1 or 2 sessions throughout the entire treatment approach. And for each of those sessions, it would be a couple of minutes that they would end up in this timeout space so that they could learn to sit on the chair. So we don't use that very often. It's used incredibly sparingly, but it's there when we need it. I'm happy to answer more about that later. So as we talked about, coaching really is key in PCIT and what really sets it apart from a lot of other really great parent management training programs, or PMT, what they're sometimes called in literature. But in PCIT, we focus on this coaching because we all know that we learn by doing. Particularly many of the parents and caregivers that we have in PCIT are ones who have historically not had a lot of success in traditional classroom environments. And so coaching is a way that really sets them up for success because the coaching is all very warm, supportive, positive. They get a lot of immediate praise for what they're doing well. And we focus on helping to shift behavior in these interaction patterns by a parallel process. So just like we're asking the caregiver to use a lot of positive skills with the child, we as therapists will use the same approach where we use a very positive style to shift the parenting behavior and in turn the interactions. I thought it might be helpful to just show some coaching pictures. I will say I am from Pittsburgh, so we are fans of the Steelers. I hesitated to even say it, but they won last night, but I thought I'd at least show some Louisiana coaching on this presentation. Some additional points that are important to consider. Sessions are usually weekly for about an hour. PCIT is meant to be short-term, but not time-limited. It takes about 12 to 20 weeks for a family to progress through. And I think that estimate is, that comes out of the research literature, where many of the families who were participating in those studies were presenting in university clinics, which are a little bit different than community-based clinics. So I think many of the families that we see in community settings have a bit more complexity, which takes it out to more of the 20 weeks. I think that's a more realistic estimate for those of you who will be planning with PCIT. We have, this says graduation occurs when the parent demonstrates that they can use the skills successfully, and when they report that the child's behavior has gone from clinically significant ranges to within normal limits. I will say there have been studies to look at where the treatment benefit happens with PCIT. And I can say that even a few sessions of PCIT make a big difference. If families get to the second part of the program, they do even better. And if they graduate from treatment, they get incredibly high treatment effect sizes, meaning that if you compared their outcome to other interventions, the outcome for PCIT would be incredibly strong. And that's why it's considered an evidence-based treatment. And here I just listed a few of the places that have included it as an evidence-based practice where it has gotten that attention. And there, like we've talked about, there have been over 40 years of research done with PCIT that have, in dozens of treatment outcome studies that have demonstrated its positive impact. I think, though, it's important to put this in context because I'll show you in just a few minutes that what we see is that when I say positive impact, what we see is that for children, you see their behavior go from clinically significant levels to within normal limits. And with parents, you see their skills shift dramatically. So by the time they finish PCIT, they're using lots of labeled praise with the child. They're doing a nice job of describing their behavior. They're reflecting everything the child says. They're using very few commands and criticisms with the child, asking few questions. And they're really using discipline when needed, but not when it's not. So you see these remarkable gains, which I'll show you in a minute. But I think it's really important to understand what parents say because that, I think, is what matters. And so we have done some studies. We actually implemented PCIT in a women's center and shelter here in Pittsburgh. And we did focus groups with parents because at the time, it was a little controversial that we were providing PCIT first as opposed to trauma-focused CBT first. And the reason that we did that, or a trauma-focused treatment, the reason that we did that was because at the time, we had the director of the center said, we have a lot of women who are re-experiencing trauma because it's social learning. Kids have been in environments where they've learned aggression. They're coming into shelter. And then when they're in shelter, rather than the other adult in that woman's life aggressing against her, her child was aggressing against her. So there was trouble, that was a problem. And the other problem was that as children, it seemed like there was a number of kids at that time who were in shelter who had some pretty disruptive behaviors. And so it was creating a lot of problems within the shelter. So it wasn't just the moms, but it was other women in the shelter who were having a hard time because of the child's behavior, because of children's behaviors. So we thought, okay, well, we're going to try PCIT, but we're also going to study it to make sure that we understand the outcomes and we understand from these caregivers what their experience has been in receiving PCIT. So what you have, I'm going to show you just a few quotes from moms who participated in PCIT as part of that project. And so what one parent says was, and I'll just read it for those who are calling in and do not have access to the webinar or the screen. So one parent said, I've never felt like I can relate to him. And it's hard not feeling like you can relate to your child, just never feeling like you can relate to them, like you can connect, until finally, after all this, I can actually connect with him. But I think it's what's been so precious to me, because I can actually talk to him. I can actually feel close to him and not just be his mother, but actually feel like his mother and nurture him. When asked about what the impact of PCIT was on their child, one caregiver mentioned, I guess it made him feel important. It made him feel like he could do things. It gave him confidence. And that stretched out to the household. So I'd say, like, okay, we're a team. We've got to do this work together, and I need your help. Another parent said, I know my son used to whine constantly. He would whine and cry for no reason. He actually started to verbalize his emotion, and he's really saying what's on his mind. And then he would start to have confidence. He would stand up for himself. So he got the confidence, he was verbalizing his emotions, and the whining sort of went down because he wasn't whining as much as he was talking more. So I think that's important, because the age that we're seeing these children is a critical time for language development, and that is something that PCIT is really helpful with. In terms of if people were satisfied with PCIT, one parent said, I wish it were available to everyone. It was just so helpful, so positive. And another parent said, I wish I had known about it a while ago, because I've had these behaviors in the house since my oldest was my only child and my youngest, because I've never been able to stop it, where I didn't find out about this until my fourth child. And I think the behaviors would have been gone a long time ago. Like we talked about, we know that for child behaviors in terms of outcomes, we know that when children complete PCIT, there are decreases in disruptive behaviors, increases in compliance. Parents report behavior improves to within normal limits. And PCIT does, when you look at the effect size of it, it's moderate to very large effect sizes. For parents, like we mentioned, they have strong skill acquisition with more positive attitudes towards their children. Parents report high satisfaction with the model, not just with the outcomes they receive, but of the process, that they really like that coaching. PCIT studies have even demonstrated that there are improvements in maternal depression and parenting stress. And parents are able, after completing PCIT, to more calmly and consistently respond to their child's behavior. Sometimes people ask about, well, okay, well, how long do those gains maintain? And there have been studies demonstrating that treatment gains maintain 1 to 6 years after completion of treatment, and that treatment gains generalize to untreated siblings, as well as to preschool and school settings. So I thought I'd also talk a little bit about the style of training that we anticipate with this collaborative. And what we intend to do is a learning collaborative. And I don't know if many of you have participated in a learning collaborative before, but the intention behind a learning collaborative is that you organize the training in such a way that, you're focused on 2 levels. One is the clinical treatment, and so the clinical side of things, the treatment approach itself. And the second is the system level or program development side of implementing a new treatment. So that's an important piece. The other thing that's really important about a learning collaborative is that the learning is structured in a way that it builds over time, and that there's a lot of opportunity for sharing across teams. So lots of organizations come together to participate in training, and then there's learning from the trainers, but also from within the group. So it really appreciates and respects the fact that we will have very experienced clinicians and administrators participating in training who have a lot to offer to the group, and we will want to make sure that we structure the learning experience in a way that we capitalize on all of that good clinical skill that's in the room. So if you'd like to learn, I'll do a brief overview of the Learning Collaborative, how we intend to structure it, but if you'd like more information, there are a couple of websites where that are listed on this slide where the Learning Collaborative approach developed. Okay, so this is what we're thinking about in terms of timeline and structure for this Learning Collaborative. So applications are due October 15th. Organizations will be notified about their status on November 15th. So to us, the launch begins. Oh, there's an error on this. This should say November 15th, 2019. I apologize. We'll fix that before these get sent out. But so the launch phase would essentially happen from this November until March of next year. And the goal of the launch phase is really to help get organizations ready to provide PCIT and clinicians ready to receive training. So there's a lot of, it sounds like it might not be that active, but it actually is. I mean, I think most people are used to when they participate in a training initiative that the first part is face-to-face training, and that's when you feel like, oh, I'm in training. No, we actually spend a lot of time getting organizations ready to take on PCIT and clinicians ready to take on PCIT. So things like organizing, ordering equipment, installing equipment, getting PCIT rooms up and going, clinicians learning about the approach, doing some online training, getting supervision structure in order, making sure you're looking through the wait list that you have, or getting referrals in to the program. All of that stuff will be happening between November 15th and the first learning session. The first learning session is scheduled for the week of March 9th through 13th. And then after that, that's a full intense week of training for clinicians. And then after that, we anticipate that clinicians will start seeing families using PCIT the week of March 16th. So that's right here. That's what is the kickoff for the first action period, because the idea is that you learn PCIT and you do it immediately. Now we'll make sure that clinicians receive a sufficient amount of support as they're implementing PCIT. We'll do clinical consultation calls with them every other week. And then we'll also come back and do a learning session, just a 2-day training that's focused on the second part of the intervention in late June 25th and 26th. And then we'll have another practice or action period where clinicians are using PCIT with their families and then receiving clinical consultation with a trainer. So like I mentioned, the launch stage, the goal of it is really to get everybody ready for training and implementation. We also will ask you during that time to develop a quality improvement team within your agency. And that group will be comprised of an administrator, a supervisor, and at least 2 PCIT clinicians. And the idea is that that's the group that will work together for this new program development. Now, I know sometimes people think like, oh, well, we already have a really strong outpatient program. This is just going to be one service within that outpatient program. And that may be the case. But what we have found is that what we want to make sure we do is do everything we can to help support your program and make sure that it thrives, which means making sure that a lot of families are coming in, that everybody within the organization's team is working with others in your organization to keep that referral flow going. So it might mean some marketing activities. It might mean training the person who takes the first phone call into the organization. All of those things will help so that those details matter when it comes to developing and sustaining programs. So we'll work on those kind of things together. And these are what we talked about. The team will meet to complete assignments, including setting up your room, ordering materials, and learning about PCIT. And we'll do some conference calls during the launch phase to help with any individual needs that might be coming up. During the learning session, that will be a very action-oriented time where we bring everybody together. The teams and the trainers will be here for 2 face-to-face learning sessions, like I mentioned. The first one is from March 9th through 13th. The second is June 25th and 26th. We'll do clinical training for clinicians and supervisors, and then implementation discussions for administrators. So we are expecting administrators to attend part of the training, and we will do learning sessions with them where it's kind of their breakout sessions that are specific to the agency administrators' needs. It's likely that those will be the last 2 days, so March 12th and 13th for administrators. And then the intention of the action periods really is to make sure that folks get a chance to practice and really embed PCIT skills in their own repertoire and also within the organization. Things that might be particularly important for you all to consider are there are costs associated with training. Not the training costs themselves, but maybe more indirect kind of costs. Things like clinician time that will be dedicated to training activities, room setup, and then some PCIT specific materials. And here's what I would urge you to consider is that it does sound like your state is trying to move in the direction of offering an enhanced rate for PCIT. And part of obtaining that enhanced rate will be that clinicians are certified in PCIT. So this training, we will make sure that we have done everything we can do to make sure the clinicians are ready to be certified. But there are some things the clinicians have to do that I just like to make people aware of. One is, of course, they have to participate in all the face-to-face training days. We'll have some skill checkouts that we do along the way. And clinicians almost always get those. That's smooth sailing. I wrote on this slide the ones that can sometimes be a little tricky. And these are requirements of PCIT International for therapists to sit for their certification. And I've included a link on the bottom of the slide if you want additional details about those requirements. But one of the things, so these are the tricky things. Attending 80% of the clinical consult calls. So that means they have to attend 20 out of 24 scheduled calls. That's usually okay. Here's where it gets a little trickier. Each clinician has to graduate 2 families, and they have to submit 4 videos for trainer review. So this is, again, something that we would talk about together in the launch phase about what do we need to have in place to make sure that they're able to submit videos when the time comes, when they're seeing families. And then they have to apply for and complete certification. Now, the certification process itself is fairly easy. They submit an application. They then go online and take this exam. And the exam, it really is just about following the current treatment protocol, which we will have covered in training in great detail. The tricky part really is submitting video and graduating enough families, which is why during the launch phase, we spend a lot of time making sure that immediately after therapists come back from training, that they're able to see families, because we have done research to understand different training methods for PCIT and what kind of really matters in training. And what we have found is that the more families a clinician sees, and the earlier they see them, the better they do in training, and the more likely your program is to sustain. So I try not to be too pushy about too many things, but that's one thing I'm very pushy about. So here are some key dates. I thought I'd just list them to make sure that you have them. Applications, we sincerely hope you will apply and participate in this training initiative. Applications are due October 15th. Notification of the training award is November 15th. We will have a kickoff call with all agencies to talk about what all the exciting things that we're planning on December 6th, which is a Friday, from 12 to 1:30. The launch phase, like we talked about, will be from November 15th to March 9th. Learning session 1 will be March 9th through 13th. Action period will follow that. Action period 1, March 13th to June 25th. We'll have a second training from June 25th to June 26th. And then the final action period will be June 26th through March 15th of 2021. So you can see we do provide a lot of support through an extended time period, just to make sure that everybody gets what they need to be successful with PCIT. We also are going to offer some office hours, we're calling them, but really what that means is that these are times that Lindsay and I have set aside on our calendars that will be available on a conference line to answer any questions that you might have. If you have questions now, in the remaining minutes, I'm happy to answer them. But it might be, if you're like me, you need to sit and think about things for a little bit. You need to take information in and then try to figure out how it would or wouldn't work with your organization. So in trying to be mindful about that, we have scheduled these times where she and I will be available, and we literally will just be waiting, hanging out to answer any of the questions or concerns that you might have. And so those office hours are on Friday, October 4th from 10 to 11, and then Monday, October 14th from 12 to 1. We intentionally put them a little bit, we spaced them out in time, and we intentionally put one right before the application was due, just in case if as you're completing things, some questions pop up at the last minute, then we'll be available to you to answer anything that has come up. So I know we have about 5 minutes left, and I wonder, Lindsay, if I missed anything that was really important that I should have said, and if we have any questions that I can address now.
Thank you, Amy. You really covered a ton of information, and I'm sure most folks listening in today, like you said, will need a little bit of time to process and really think about the concerns and questions they may have. I will say, so I've received a few questions, and I'll just answer those quickly because they're more bookkeeping type of questions. So a few people asked if CEUs will be offered. So the answer to that is yes. The Center for Evidence to Practice will be applying for PCIT training CEUs for both social workers and licensed counselors. And we do not have a set number yet. We'll be communicating that probably closer to when the kickoff call would be. We'll let you know how many CEUs we are approved for. Another question we've received is the cost of the training. So the Center for Evidence to Practice has funds through Medicaid and the Office of Behavioral Health to support our mission of expanding access to EBPs for Medicaid providers. So I just want to reiterate that your agency must accept Medicaid. That is our main prerequisite in order to be accepted into any of our trainings. So, and this PCIT Learning Collaborative will be free of cost to agencies who are selected. And that goes with saying that outside of so we'll be paying for the expense for you to attend the training and the manuals needed. However, your agency will be responsible for other costs, such as paying for your travel expenses, budgeting accordingly for the time that you will miss for the training and consultation calls, and making your room and tech changes. So if you look at the RFA, all of this information is thoroughly outlined in there. So I encourage everyone who hasn't already to take a deeper look at that, because there's some more cost-specific information explained there. Let's see. Okay, so Jody asked for office hours if there's a number that we can call, or if it's best to submit questions through email. So today I put up the links to register through Eventbrite and the Zoom link for the office hours. So if everyone goes to the Center for Evidence to Practice website, which is laevidencetopractice.com, under our events and training tab, you will find the office hours. So if you click on those, it'll lead you to the information for those calls, and we'll send out in the next day or so, we'll be sending out our October newsletter, and we'll make sure to link everything in there as well. And for questions, you're welcome to email or just pop in. Like Amy said, we'll just be waiting those hours and just join in on the call, ask your questions, and yeah, we'll just be there to support whatever your needs are. I received a question as well, and Amy, this might be better for you to answer, but somebody asked if it would be possible to provide PCIT through a telehealth service.
It is. So there is a group who does a telehealth kind of application of PCIT. I think, though, that that's something that, here's the wonderful thing. PCIT has been around for a long time, and there have been a lot of folks who have been interested in extending it and stretching it to reach different populations and in different formats. So for example, there's standard PCIT, and then there's PCIT that's going to for children on the autism spectrum, for separation anxiety disorder, for selective mutism, for developmental disabilities. So it has this broad applicability to different populations, and people have also taken it and applied it with different formats. And so that's where I would see that telehealth, just like we took it on the road and have an in-home version of PCIT, there also have been folks who've done group-based PCIT. But what I would say is for this initiative, we would want to make sure that everybody, given that your state is starting to implement PCIT, and that this learning collaborative will focus on clinic-based PCIT, that is something that we could definitely talk about, but it would be kind of I would see that as a second step, because what we'll want to do is make sure that you're really grounded and trained in the original protocol with PCIT, and then that's an important next step, I think, particularly given how rural parts of your state are. And I have to say, I've worked a lot in West Virginia and Pennsylvania. People don't think about it being very rural, and it's certainly not quite as rural, like, for example, as West Virginia, I'm sure Louisiana, but it does have a lot of rurality in the word right there, but in the middle of the state, in the upper north central part of the state. So I know what you mean. There's definitely a need to make sure that we're getting the services to families in hard to reach areas.
All right, so I received another question about if on-site training would be provided in Lafayette. And then Jody just asked where the face-to-face learning sessions will typically take place. So it seems like folks are interested in knowing where the physical location will be for the Learning Collaborative. And we have decided that that will really depend on the agency selected. So once we have an idea of who will be participating in the training, we really want to try to make the training through the Center for Evidence to Practice as accessible to the agencies as possible and reduce travel expenses. So for example, if we select agencies that are for the most part located in central or northern Louisiana, we'll make sure to have our training venue in that part of the state. So by the time of the kickoff call, we will announce the location and be able to provide more information on that. I would also, just in these last few minutes, I'd like to reiterate. So Dr. Herschell mentioned that Louisiana is working on an enhanced rate for PCIT. And that is correct, that the Office of Behavioral Health is exploring that for not just PCIT, but for the other EBPs. And so we currently do not know when that will be released. So we are encouraging agencies when thinking about pursuing EBPs to really look at your business models. We'll have some resources coming out to support agencies and business models for evidence-based practices. But as we're not sure of when OBH will publish that enhanced rate, we are encouraging just making sure that you can financially support this with the time and resources needed for successful implementation. And then in terms of the service definition, that has been published. So if you go to our website, we have that linked in on the page with our interactive map. It's the provider manual. So you can go there and just read through the PCIT service definition. So when you start billing Medicaid, you'll be encouraged to identify when the services are PCIT. Do we have any other questions? Janine Morris, do you have a question? Oh, there we go. Oh, okay. So Janine just asked if the application is not available until the October date. And no, the application has already been released. And if you go to our website, laevidencetopractice.com, if you click on events and training, you'll see PCIT, and you can click on that. It'll download the Word document. And also, if you have not been receiving our newsletter updates, on our website at the bottom, you'll see a place to enter in your email and get onto our MailChimp listserv. So we send out frequent monthly updates regarding training, webinars, other things that are going on pertaining to EBPs. So highly encourage everyone on this call, if you haven't already been receiving our emails, to make sure you're subscribed. All right, Dr. Herschell. So I think we answered the questions that I had received so far. And we just received another, okay, so training costs would be free if selected. And yes, yes. So as I mentioned, the Center for Evidence to Practice is sponsoring this training. So the training will be free of cost. All of the in-person sessions and consultation calls and manuals. However, agencies will be responsible to make the room modifications, purchase the technology, which would be the bugging your device, or however you choose is best to set up your facility, and other expenses associated with training, such as travel. So please read through the RFA. We tried to include as much information as we could, and we do encourage everyone, if you're not a senior leader or an administrator, to just share that, discuss with your agency, and includes private practice clinicians. So our main criteria to participate in training through the Center for Evidence Practice is that you must accept Medicaid. All right, Dr. Herschell, do you have any final words before we wrap up?
No, I don't. I just want to, I guess the only thing I want to do is just say thank you very much, everybody. We really appreciate you participating today, and we really will be happy to answer any questions you might have. So I hope to hear from some of you during our office hours.
Excellent. Thank you, everyone, so much. We really appreciate your interest in PCIT and hope to see you at our office hours. Feel free to reach out by email as well. And take care. Have a great afternoon.
Thank you.